So hi, this is Stephen again. We're just going to go over a newer procedure that's been put in the New Mexico scope of practice, and that's using the Morgan lens for eye irrigation. A couple things about eye irrigation. When you get something in your eye or a chemical in your eye, there's a couple of things that can lessen the damage. The first one is if you can start treatment as soon as possible of the irrigation, even before you reach the emergency department, it's going to decrease the severity of damage to the eye. And if you can use something that will reach all the regions of the eye so that you can dilute the chemical or wash away any kind of particulate matter, you can reduce the damage to the eye. And if you can use something that can be kind of a prolonged irrigation of the eye without interruption, of course that also will decrease the severity of the injury to the eye. And so what we're going to talk about is Morgan lenses, which kind of meets all of those criteria. Ocular burns represent about 7 to 10% of ocular trauma that presents to the emergency room. Of this, 84% are chemical burns. And depending on who you read, there's either more alkali or an even number of alkali to acids. And then the remaining 16% are typically thermal burns. 15 to 20% of patients with facial burns exhibit ocular injury. In 1995, approximately 1/3 of corneal transplants were done on eyes that sustained chemical burns. So even if the eye can't be saved, if we can irrigate it, we can maybe maintain enough healthy tissue in the eye to be able to allow a corneal transplant later on. So there's varying uses for the Morgan lenses. The most common are the three that we just talked about, alkali burns, acid burns, and thermal burns. There are some other reasons we'd use it if patients got irritants in their eyes. They give the examples of gasoline and detergents. We could also think of things like pepper spray, non-embedded foreign bodies or a foreign body feeling. And then there's a couple of situations where we probably wouldn't use them on the ambulance, but they do use Morgan lenses for those, and those are those last three. So we know that acids vary in strength, and on the pH scale they go from 0 to 7, hydrochloric acid being a 1, so very strong, and then 7 being water, which is considered neutral. And when we think about an acid burn on our skin or in our eyes, anywhere in our body, what it does is it causes a coagulation necrosis, and so we get this layer that the acid won't burn through. It would kind of melt the cells, and then it causes a layer that protects all the cells underneath. Well, that's kind of the opposite of what happens in alkalis, and alkali burns are much worse because of what they do to the skin cells. They produce a liquefaction necrosis, and they continue to burn down through the cells. They don't form a protective layer. And we know that alkalis are measured from neutral, which is water, up to 14. And so something like sodium hydroxide has a pH of 14, and that's like your lye or caustic soda. Concentrated forms of either might generate pretty significant heat as it burns down through, and the heat is usually dissipated by water, and there's not much water in our eyes, but when we irrigate the eye, that allows that heat to be dissipated as well as diluting the chemical. So alkali burns are the most serious of all of the ocular burns, like we said, and it's because of this liquefaction necrosis that'll, the alkali just burns right down through all of these cell layers, and it happens pretty rapidly. And in some cases, depending on what the substance is, it can reach the anterior chamber of the eye within 5 to 15 minutes of exposure. Now, these don't always cause pain. They, of course, all will at first, but the pain might lessen with the alkali burns as it kind of burns through all of the nerves in the eye. Once it reaches the anterior chamber, then we can have some irreversible damage done to where we won't even be able to fix it with like a corneal transplant. There are several common sources that contain alkali. You might see lye and drain cleaners. You might see calcium hydroxide, which is found in bleach and pool chlorination solutions. Sodium azide is the propellant in the airbags, and that's also a strong base. Sodium oxide or lime that you might see in plaster or cement. Ammonia in different cleaners and detergents, and magnesium hydroxide and phosphorus that's found in sparklers and flares. All of these can cause alkali type burns to the eyes. So when we look at acid burns, we know that they kind of form this coagulation necrosis, and it slows the penetration of the acid. But these burns might look a lot worse than an alkali burn at first, but the damage is usually not as severe. Some of the most common acids are listed here. Hydrofluoric acid is a weak acid, but it actually does produce liquefaction necrosis just like the alkali solutions, and it scavenges calcium from the body. And so sometimes these patients can be, if they get good enough exposure, they can be hypocalcemic and need extra calcium given to them. Hydrofluoric acid is usually found in like glass etching compounds or rust removers, usually in the industrial type setting. Sulfuric acid, usually found in automobile batteries, another very common exposure to an acid in the eyes. Maybe some toilet bowl cleaners. And then hydrochloric acid is also found in toilet bowl cleaners and lab type situations. Acetic acid is found in printing, disinfectants, and hair products. And acetic acid is actually a form of vinegar. Of course, vinegar is much more dilute, and we're talking about acids that are much more concentrated. And then formic acid, which is used in like airplane glues and adhesives in manufacturing. The recommendation for alkali and acid type burns are to monitor the pH of the eye using pH paper until the eye becomes pretty much neutral. That may or may not be something that you carry on the ambulance. Usually, we're going to be irrigating the eye for at least the amount of time that it takes us to transport a patient. The third group of chemicals are considered just irritants, and they might include things like gasoline, pepper spray, and some household detergents. And usually what we'll do is just irrigate these patients for 20 to 30 minutes at a minimum. So usually, that's going to get you to the emergency room. These are the materials that are necessary to use the Morgan lenses. And actually not all of this is necessary to use the Morgan lenses, but you definitely do need some Morgan lenses. They run about $26 a piece is what I could find out on the internet. And you may need one or you may need two. Just realize that you might have a problem with both eyes, but the pain from one eye is masking the pain in the other eye. So you definitely need, at least your Morgan lenses. They do make a Morgan lens delivery set, and you can also use IV tubing. The difference between the Morgan lens delivery set is that you spike one bag, and then it has two connections at the end, one for each eye with a clamp on them. Suitable irrigation solution. You can pretty much use almost any type of irrigation solution. The one that they recommend is LR because of the pH being much closer to the eye than, say, like saline or some other type of fluid. They recommend these Mediduct to absorb the outflow, and you'll see a picture of this in a little bit. That's another product this company sells, or lots of towels just to absorb it. Just make sure not to make your patient really cold when you're dumping all this fluid onto them. Topical ocular anesthetic, if available. The anesthetic will help reduce pain. It will help reduce kind of the feeling of something in their eye, and it might ease your patient's anxiety with having something in their eye, flushing out their eyes. And the ones that New Mexico has on their list is proparacaine and opthane. There is another one called tetracaine, and it is a different formulation than the ones that are on the New Mexico list, so I'm not sure whether that would be legal or not, but the ones that are on the list are proparacaine and opthane. And then possibly some pH paper to measure the pH of the eye, but usually that's going to be completed in the emergency room. So step one of insertion is to use a topical anesthetic if you have it, and then of course attach your Morgan lens to either the IV tubing or the actual Morgan lens delivery set. If possible, if the patient has contacts in, if you can get them out, that's better. Sometimes they may be very difficult to remove, and so if you can irrigate the eyes for a little bit, then they may be easier to get out after a small period of irrigation. We move on to the second step. So step two is actually inserting the lens, and a couple of tips for doing this. One is to start the flow slowly of the LR or whatever solution you're using, and have the patient look down and then pull up their upper eyelid and place the top of the Morgan lens in towards the top there, and then have them look up, retract that lower lid and drop the lens in, and just have them close their eyes and then adjust the fluid to the amount that you want. So here you can see this Metaduct that they sell on the side of the patient's face, and this is kind of a fluid collection system. And so you could also use some towels or something like that. And you're just going to continue to irrigate the patient until, probably until you reach the hospital. But in the hospital will be until the pH of the eye returns to normal. And you can see right here, this is the set that they sell, and it's got two ports for the Morgan lens. So you can hook up two to one bag of fluid. Another important point is don't let your fluids run dry, because then you do have you lose that cushion, and then you have the Morgan lens sitting right on the eye, and that becomes very irritating to the patient. This is just another chart that Mortan, which is the company that makes Morgan lens, provides, and it's just shows the same thing and kind of shows the Morgan lens, I think, a little bit better than the PowerPoint presentation did, and also shows how to take them out. Of course, another important point here is that you continue the flow until you have the lens out, and then you terminate the flow. I've seen people take these out before, and if they turn off the flow before they take them out, it's almost like a suction cup, and you can hear it just come right off the eyeball. It doesn't feel so good for the patient. So, same thing about removal. Continue the flow, have the patient look up, retract and hold the lower lid, and then remove the Morgan lens. We talk about how long to irrigate the eye. Well, for those things that we classified as irritants, which was like gasoline and pepper spray, usually 20 to 30 minutes at a minimum, so many times probably the length of our transport. But for things that are more penetrating, like acids and alkalides, we want to make sure and irrigate with 2 liters of fluid per eye. So that's 4 liters of fluids of either normal saline or lactated ringers. I know a lot of people probably don't carry LR on their trucks. The difference in pH is the pH of our tears is about 6.5 to 7.6 on that pH scale, but when it's actually measured in the eye, the pH is closer to actually 8, so it's just a little bit alkali. And when you look at the actual solutions, the pH of the LR is about 6 to 7.5, and normal saline can range from anywhere from 4.5 to 7. And so, the lactated ringers has a little bit more of a buffering solution and will bring the pH back to normal a lot quicker. So, if we were to measure the pH, then we'd want to wait 5 to 10 minutes after irrigating and then measure the pH, and we want it somewhere between 7.5 to 8. If it's not there yet, we want to continue to go ahead and irrigate the eyes. This cul-de-sac, I've never heard it called this, but I've heard it called like the inner canthus or the medial canthus, and it's basically the corner of your eye on your nose side is what they're talking about. One thing about taking a history for these patients is we don't want to delay irrigation, to get a full history. Once we know that they've had an exposure, we want to go ahead and begin irrigation. Some of the questions that we might want to ask is, when did the injury occur? What substance was involved? We want to know if the patient's allergic to any medications, is probably before we instill the proparacaine or Opthane. Was the patient wearing safety glasses when the injury occurred? And of course, are there any other injuries? You may also want to ask if they've done anything for their eyes or put anything in their eyes. That might be important to know also. There are some contraindications to using these. Most of them have to do with an actual hole in their eye. So if they have a foreign body impaled in there, or they have something that went through the sclera and is inside the eye, we probably wouldn't want to start using the Morgan lens. This slide goes over kind of what we talked about already, but basically the company recommends using LR, and it's because of the pH range. And so if you see the pH here of normal saline versus the pH of lactated ringers versus the pH of normal tears, they recommend using LR. You can use normal saline, but they do recommend using LR. So some patients might not like things put in their eye, and or maybe children or something like that. You might do a couple of things that kind of alleviate the anxiety with having something put in their eye. One thing is that if we can use those drops, the proparacaine or the Opthane, to numb their eye, then that will make it easier to put the Morgan lens in. Just remember that when you put those drops in, they can feel you'll feel a stinging sensation for about 10 to 15 seconds, and then that goes away, and then their eye is numb. And that numbing medicine usually lasts about 20 minutes or so, 20 to 30 minutes. So if you need to put some more in, just kind of pinch the Morgan lens tube. It's really soft. You just pinch it off and then put some in that inner corner of their eye, a couple of drops of the proparacaine, and then go ahead and start up the Morgan lens again. You might also tell them that the lens isn't actually sitting on their eye, that it's the fluid that's on top of their eye, and you might let them know that it's going to cool down their eye because their eye might be burning, and so the fluid will actually cool that down. And you can tell them that they can close their eyes. It's okay to blink, it's okay to close their eyes when they have the Morgan lens in place. So maybe some of those things would help. So the company says these are the benefits of the Morgan lenses. They do free up a person to take care of the patient while their eyes are being irrigated, so you don't have someone sitting there pouring fluid into their eyes, so that's true. 100% of the irrigating solution is delivered right into the eye, so you're getting really good fluid irrigation of the whole eye. The patient can be ambulatory. I suppose they can be ambulatory, but on the ambulance, it's just you can continue to irrigate the patient while you're moving them. So, you know, if they're on the gurney, you can be rolling them, and as long as you've got the LR bag above their head, they're going to continue to be irrigated. Highly cost effective. I'm not sure what they're comparing that to. Like I said, each lens costs about $26 a piece. I'm not sure how much the IV sets cost, but you know, you can decide whether $26 a piece is highly cost effective or not. So in wrap up, you know, we learned that burns are some of the most urgent of the ocular emergencies, especially alkali type burns, and that if we can start copious amounts of irrigation that's prolific or reaches the whole eye, the less damage will be done. And if this can be started, you know, either at the scene or en route to the hospital, that's better. And then the irrigation should be continued until the pH of the eye returns to normal. And so if we're not checking it, we should continue irrigation until they can check that in the emergency room. Then of course that they recommend a more neutral solution like LR. Of course, saline can be used. This is just the company that provides the Morgan lens. It's called Mortan. So thanks for listening. There's a link to the video that's about 10 minutes long that Mortan has, and if you watch that, you should have all the answers for the questions that refer to this in the trauma test. Thanks.